Welcome back, guys. Now in this video let's discuss about the topic of infective endocarditis. We have already discussed the rheumatic fever. Now in this video let's discuss the infective endocarditis. So in the name itself it is there, endocarditis. Even in the topic of rheumatic fever and rheumatic heart disease we have discussed about the endocarditis. How it is different, how this endocarditis is different from the rheumatic endocarditis? It's because in the name itself it's there, infective endocarditis. It is the infectious agent leading to the inflammation of the endocardium. Okay, their endocarditis is because of autoimmune reasons. Here, this endocarditis, infective endocarditis, what exactly is it? It is the inflammation. Let me write here. It's the inflammation of what? Of endocardium. Because of an infectious agent, because of or due to infectious agent. Okay, infectious agent, or there is some infectious cause leading to this endocarditis. Now you can ask me, what is that infectious agent, sir? Which infectious agent or which bacteria or which virus is leading to this endocarditis? Now the answers are different. See, now if you ask me, this infectious agent leading to infectious endocarditis in a native wall, okay, in a native wall, native wall. So what exactly is native wall? Native wall is something normal, the wall which is present in the heart. It's not something prosthetic, it's something natural. Okay, so native wall, it is different. In prosthetic wall endocarditis is different. Okay, in prosthetic walls it's different. And in IV drug abusers, the answers are a little different. IV drug abusers. Okay, in IV drug abusers, it's a little different. See, native wall is a wall which is present biologically. It's a biological wall which is present in the heart. Now, what is the infectious agent which is causing, okay, native wall infectious endocarditis? Here again let's divide this into two parts. Native wall endocarditis, it is different in community acquired cases. Community acquired. So in community acquired and in nosocomial patients or hospital acquired. Nosocomial means hospital acquired. Okay, so now the question, what is the most common infectious agent leading to native valve endocarditis in the general community? Then the answer is streptococci. Okay, streptococci. So streptococci is the most common cause of native valve endocarditis in a community. But in nosocomial patients, then the answer will be Staph aureus. Okay, so Staph aureus is the most common infectious agent. Now prosthetic valves, see, after having, even the prosthetic valves are made up of the biological matter. Okay, now after getting a prosthetic valve, you can get this endocarditis, infectious endocarditis within a year or after a year. So based on the timeline when you are getting the endocarditis, the prosthetic valve endocarditis is divided into early prosthetic valve endocarditis and late prosthetic valve endocarditis. Late is after 1 year. Early is before 1 year. Okay, so what is the most common cause of early prosthetic valve endocarditis? Then your answer should be Staph epidermidis. Okay, Staph epidermidis, I hope you know, this is a cons organism, okay, coagulase negative organism. And after 1 year, the best answer will be again streptococci. Okay, streptococci. Now after this, in an IV drug abuser, see, usually IV drug abusers, what they will do? They will take the injections, okay, they are abusing the drugs, they are taking the injections. Whenever they are taking the injections, directly they are pumping the drugs into the veins. Now all this venous blood, where they will drain? All the venous blood, it will go into the right side of the heart. So the right sided valves are going to be most commonly affected. So what is that right sided valve between right atria and right ventricle? It's a tricuspid valve. So in IV drug abusers, if you get a question, which valve is most commonly affected? Definitely it is a tricuspid valve which is going to be most commonly affected. So keep that point in mind. But apart from that, let me write here. So in IV drug abusers, right sided valve endocarditis is going to be most common. And what is the most common causative agent leading to this right sided valve endocarditis? The best answer is Staph aureus. Okay, Staph aureus. Tricuspid valve is going to be affected. Right sided valve, that's the tricuspid valve. And left sided valve, if they ask you, in IV drug abusers, not only the right sided valve, even the left sided valves can be affected. Then what is the best answer? Left sided valve. Again, the best answer is Staph aureus. Okay. If you don't find the Staph aureus, then the next best answer is going to be enterococci. So this is a broad classification of infectious agents causing infective endocarditis in different setups. Okay. So in a native valve endocarditis, if it is a community acquired, it is streptococci. If it is hospital acquired, it is Staph aureus. In prosthetic valves, before 1 year, that's the early onset. Before early onset, it is Staph epidermidis. After 1 year, it is going to be streptococci. In IV drug abuser, it doesn't matter whether it is right-sided valve endocarditis or left-sided valve endocarditis. The best option is going to be Staph aureus. And remember, in IV drug abuser, the tricuspid valve or the right-side valves are going to be most commonly affected. Okay. Having said that, the one important point which I want you to know is, see, now every day we have some amount of bacterial infestation. Some amount of bacteria definitely will go into my body, definitely on my skin. Some amount of bacteria will be there, definitely bacteria will be there, and that bacteria will take access into my body. Do you think that this bacteria can cause the infective endocarditis? No. A healthy person, the healthy valve, the healthy endocardium cannot be attacked by this bacteria. Okay, healthy endocardium or the healthy valves are not going to be damaged, are not going to be inflamed because of this bacteria. Having said that, it's those valves which are already damaged, which means there should be some pre-existing valvular problem. There should be pre-existing heart condition, so that now it will be an advantage. That pre-existing heart condition or the pre-existing valvular damage, it will be an advantage for the bacteria to lead to infectious endocarditis. So the one important keyword which I want you to know is, infectious endocarditis will develop in a person who is having pre-existing heart conditions. Okay, that's the one important point which I want you to know. So let me write some more important points here. What's the most common valve? Was most commonly affected in infectious endocarditis. It is a mitral valve. Don't forget, even in rheumatic heart disease, the mitral valve is going to be most commonly affected. Okay. So I have already said you, there should be a pre-existing valvular lesion that will lead to infectious endocarditis. So which pre-existing valvular lesion, whether it is mitral regurgitation or mitral stenosis or mitral valve prolapse, which valvular lesion can lead to this infectious endocarditis most commonly? See, let me write here, valvular lesion leading, that's the most commonly, okay, valvular lesion leading to infectious endocarditis. The answer is mitral regurgitation. Okay, so valvular abnormality highly associated with this valvular lesion, highly associated with infectious endocarditis is mitral regurgitation. Okay, next. So let me write here, note, patients with pre-existing, okay, valvular lesions are at highest risk of developing infectious endocarditis, MCQ. Okay. Having said that, now how to establish the diagnosis? Okay, how can we say that this fellow is having infectious endocarditis? Now, how can we establish the diagnosis of rheumatic heart disease or rheumatic fever? There is a revised Jones criteria. Okay, migratory polyarthritis is there, pancarditis is there, subcutaneous nodules, erythema marginatum and Synapse chorea, all these things are there. Okay, in the same way, just like revised Jones criteria over there, here the criteria which is used for the establishment of diagnosis in infectious endocarditis, it's called as the modified Duke's criteria. Okay, the modified Duke's criteria. According to the modified Duke's criteria, at least the patient should have two major criteria or one major criteria along with three minor criteria, or at least the patient should have five minor criteria. Still now, I haven't discussed any major criteria or minor criteria. You don't know. But what I am saying is, to say that this patient is diagnosed, is having infectious endocarditis, the patient should have at least two minor criteria or one major plus three minor criteria or at least five minor criteria. Okay. So, having said that, now let's discuss about what are the major criteria. How many major criteria are there? There are three major criteria. Okay. There are three major criteria. What are these three major criteria? The criteria number one, okay, is blood culture. Okay, positive blood culture. The blood culture of the patient, if you take the blood from the patient, this blood should have the microorganisms. Okay, there is infectious endocarditis happening, right? There is some infection going on in the heart. So, heart is pumping all these microbial agents. See, now heart is acting like a factory. Now, there are trillions and trillions of bacteria which are present in the endocardium of the heart. Now, from here, this bacteria are getting disseminated throughout the body. So, everywhere in the body and everywhere in the blood, you are going to find the microorganisms. So, if you collect the blood from this patient and if you culture this blood, so definitely there will be growth of the microorganisms. So, blood culture is going to become positive. It comes positive. Positive with which microorganisms? That's important. So, the blood culture should be positive. Okay, how many blood cultures should come positive? At least two blood cultures. Okay, two blood cultures should come positive. Okay, so you have to collect the blood with the 12 hours apart, and at least two blood cultures should come positive. With which microorganisms? With microorganisms like streptococci or staphylococci or has a group of organisms Okay, what are Hesse group? Here I have given you. So these are the Hesse group of organisms like Haemophilus species, Aggregatobacter, Cardiobacterium and Echinella and Kigenella species. Okay, these are the Hesse group of organisms. Or one special thing which I want you to know is Coxiella brunet. Coxiella brunette. See, what is something special about this Coxiella brunette? Okay, two blood cultures should come positive with other organisms. With other organisms, two blood cultures should come positive. But if one blood culture, actually this is a very atypical organism. If you have at least one blood culture, if it is coming positive with Coxiella brunette, 100%, yes, you can take it as a major criteria. But with other organisms, you need to have two blood cultures coming positive for the same organism. Okay? So, which means like, no, first time, yes, in one blood sample, okay, you have taken one blood sample. Now, you are sending it for the pathological lab and you are just culturing it. After 12 hours, you are taking one more blood sample, and in first sample as well as second sample, if you have the same organism, yes, then you can say that the two blood cultures are coming positive. But with Coxiella brunette, the exception is even with the one blood culture coming positive with the Coxiella brunette, you should consider it as a major criteria. Okay. So now tell me, what is the first major criteria? The first major criteria is the laboratory thing, that's the blood culture of the blood for the organisms. Okay, next, the second major criteria which I want you to know is echocardiographic finding. Echocardiographic finding. What is that echocardiographic finding? On echocardiography, if you find intracardiac mass or abscess or any valvular defect. See, if there is any intracardiac mass, actually, what is happening? For example, look here, guys. Imagine this is the left ventricle. Okay. Now, what is this wall? This is the mitral valve. Now, what is happening is the endocarditis, right? So, definitely mitral valve is going to be affected. Now, when the mitral valve is affected, these bacteria, actually, they are growing. Okay, trillions and trillions of bacteria, they are actually growing on this valve and they are forming the abscess. And they are even forming the vegetations. Okay, these masses are nothing but the trillions and trillions of microorganisms. So you can see these oscillating vegetations. These vegetations, they are septic vegetations. They are not sterile vegetations like in rheumatic fever. In rheumatic fever, the vegetations are going to be present along the line of closure and they are very much sterile in nature. But these vegetations are absolutely septic. Okay, the walls are getting damaged and as the walls are getting damaged, now yes, platelet microthrombi are going to accumulate over there. Now platelets are coming and they are forming a small clot, but all this clot is full of microorganisms. And on echocardiography, you can actually see these oscillating vegetations which are septic in nature. One more important point which I want you to know is these vegetations, these abscess, what they will do is the third criteria. Okay, the criteria number 3. Let me write it over here. The criteria number 3 is new onset murmur. Okay, new onset murmur. Now, whenever you find this word new onset murmur, actually it's a keyword. Okay, so 3 criteria are completed. The first criteria is positive blood culture. Second criteria is an echocardiographic finding, and the third criteria is an auscultatory finding. That's a new onset murmur. Why there might be a new onset murmur is because of the valvular damage. The valves are getting damaged. Now, the valves are having this abscess. This abscess might totally drill through the wall, leading to perforations within the wall, leading to regurgitation of blood. That regurgitation of blood can lead to the murmurs. Okay. So, for example, let me show you. If this is a wall, this is the left ventricle, here is the valve which is present. Now, this valve is having total perforation because of the abscess. The total wall is going to have, in the wall there is going to have a perforation. Because of this perforation, there will be regurgitation of the blood. Now, which is happening newly, that can be called as a new onset murmur. So, remember, a new onset murmur, whenever you see this word, think about infectious endocarditis. A known case of a mitral regurgitation. Now he is developing a known case of mitral regurgitation, a known case of rheumatic heart disease. Now if he is developing a new onset murmur, think about that. This patient, he is having some pre-existing heart condition. Now he is developing a new onset murmur. So you should think this patient might be having infectious endocarditis. Okay, so you should go for the echocardiography. In echocardiography, what you will find? You might find an abscess, or you might find an oscillating intracardiac masses. You have to go for the blood culture. In the blood culture, you can get the positivity for the microorganisms if it is infective endocarditis. So these are the major criteria which I want you to know. Okay, so what is the name of the criteria which is used to put the diagnosis of infectious endocarditis? The criteria name is called as the modified Duke's criteria. According to modified Duke's criteria, either you should have 2 out of these 3 major criteria, at least 2 should be positive, or 1 major with 3 minor, or 0 major, at least 5 minor criteria should come positive. Okay, so now we have completed the major criteria. Now after the major criteria, we will discuss the minor criteria, but before going to the minor criteria, I want you to know these vegetations are made up of what? These vegetations are there, these intracardiac masses, these vegetations are there. Now these vegetations in infective endocarditis, they are made up of what? These vegetations I have already taught you, they are septic vegetations. Okay, they are septic vegetations. So what are present? Bacteria will be definitely present. Okay, fibrin. Because of the damage to the walls, fibrin is getting deposited over there, clots are forming. So platelets will be seen. Okay. As well as inflammation is going on, some inflammatory cells will also be seen. Inflammatory cells are also going to be seen. So vegetations which are seen in infectious endocarditis, they are made up of bacteria, fibrin, platelets as well as the inflammatory cells. Now after that, let's discuss about the minor criteria. Major criteria completed, minor criteria. How many minor criteria are there? There are actually 5 minor criteria. Okay, 5 minor criteria. So what are these 5 minor criteria? The first minor criteria is pre-existing heart condition. Okay, pre-existing heart condition or IV drug abuse. See, these are the risk factors. No, pre-existing heart condition is a risk factor, and IV drug abuse is a risk factor. And don't forget, IV drug abusers are going to have the right-sided valve endocarditis. The tricuspid valve is going to be affected. So this is the first minor criteria. The second minor criteria is fever. With the temperature, it's an infection, right? So definitely fever will be there. Temperature greater than 38 degrees centigrade. And the third minor criteria is immunological phenomena. From here, these are the very important MCQs. Okay, immunological. Immunological phenomena. See, in the body, massive bacteria are growing. Okay, the heart is pumping this bacteria throughout the body. Now, what body will try to do? The body's immune system will try to act against this bacteria. So, body is trying to produce the antibodies. So, these antigen antibody complexes are circulating throughout the body. Due to deposition of this antigen antibody complexes in different parts of the body, there will be some immunological phenomena. For example, imagine I am a patient who is having infective endocarditis. Now, if I am the person who is having infective endocarditis, my heart is sending all this bacteria throughout the body. My immune system is activated and my immune system is producing the antibodies. These antibodies will go and attack the antigens. So, this antigen antibody complexes which are circulating in the blood, they will be deposited in different tissues, leading to different immunological phenomena. For example, if these immune complexes, if they are deposited in the kidney, what will happen? The patient is going to get post-streptococcal glomerulonephritis. For example, something like that. Streptococcal infection happened, streptococcal endocarditis is happening, infectious endocarditis is happening. Because of the immunological phenomena, the streptococcal, the antigen antibody complexes, they are deposited in the kidney, leading to post-streptococcal glomerulonephritis. Now the inflammation have started in the kidneys. Okay, post-streptococcal glomerulonephritis is happening. Now, this immune complexes, now they are going to be deposited in the retina. Okay, they are deposited where? They are deposited in the retina, leading to the retinal hemorrhages. Which are called as Roth spots. Retinal hemorrhages, R for R. They are called as here you can see these oval shaped hemorrhages which you are able to look over there. They are the oval shaped retinal hemorrhages. They are called as the Roth spots. Okay. So this is something important. These Roth spots, they are not only seen in this specific condition. Roth spots are also seen in other conditions like diabetes mellitus. They can be seen in leukemias also. Okay, Roth spots are not something specific. Remember, Roth spots are not specific. They are seen in other conditions like diabetes. They are seen in leukemias, anemias, different conditions also. So this immunological phenomena is because of the immune complex deposition in the kidney, leading to post-streptococcal glomerulonephritis. The immune complex deposition within the retina can lead to the Roth spots, and these immune complexes, they are deposited even in the soles and foot. Okay, these immune complexes are getting deposited in the soles and foot also, leading to Osler nodes. Osler nodes. See, remember Osler started with ah sound, right? Ah means something painful. So what are these Osler nodes? They are painful. They are painful. Maculopapular red, maculopapular lesions, which are nothing but immune complex deposits. Where immune complex deposits? In the finger, in the tip of the fingers, in this area, okay, in the pulp of fingers. Okay, these are the points which I want you to know. So Osler nodes are painful. That's the important point. Osler nodes, remember, they are the painful red maculopapular lesions because of this immune complex deposits in the soles and fingers. Okay, in the soles and fingers. Now after this, the third criteria, the third minor criteria is also completed. The fourth minor criteria is called as a vascular phenomena. Okay, the fourth criteria is a vascular phenomena. What are these vascular phenomena? This vascular phenomena, it is due to what? It is due to septic emboli. It is due to the septic emboli. What does I mean by these microorganisms? They are going to damage the blood vessels. They are going to damage the endothelial lining of the blood vessels. The microorganisms are going to cause the damage to the endothelium of the blood vessels. So you are going to have some small thrombus. Now on this thrombus also microorganisms are growing. Now this septic embolize, okay, or the septic thrombus, they are going to detach from there, and what will happen? They are going to go through the entire body. Or in a simple way, try to understand like this. Imagine I am the one who is having the infectious endocarditis. Okay. Now if I am having infectious endocarditis in my heart, this endocardium is going to be affected. Endocardium in the heart is going to be affected. So what is going to happen? The platelet microthrombi are going to form, which are totally filled with the bacteria. Now this vegetation, this septic vegetations are very much friable. The septic vegetations, they are not firm, they are very friable, they are very loose, they are very soft. They will detach from the wall. Now they will enter into the systemic circulation. Now they are going to spread into different parts of the body. So these are called as a septic emboli. So important point is this vascular phenomena. It is because of the septic emboli leading to arterial emboli. So these emboli got into the arteries. Now, for example, if this emboli, if they go into the heart, okay, if they go into the lungs, what will happen? They will block the pulmonary vasculature, so leading to septic pulmonary infarcts. Septic pulmonary infarcts. Okay. Not only that, these emboli, they will go into hands and foot, and there they will cause Osler nodes. Sorry, not Osler nodes, sorry. They will cause Janeway lesions. Janeway lesions. See, Janeway lesions, they are something similar to the Osler nodes, but Janeway lesions are non-painful, they are non-tender. Since this emboli, septic emboli, they got disseminated throughout the body. Now the septic emboli will also come and get deposited in the hands and soles. So these painless nodules, which are getting deposited in the palms and soles, they are called as the Janeway lesions, and the Janeway lesions are non-tender. This septic emboli will also go and get deposited. They also go and deposit in the nail bed, leading to small hemorrhages, which are called as a splinter hemorrhages. Okay. Now you can clearly see the splinter hemorrhages over here in the nail beds. There are these hemorrhages which are present. Okay, there are these hemorrhages which are present in the nail beds. These are called as the splinter hemorrhages. Here you can see a oval shaped hemorrhages in the retina. They are called as the Roth spots. And here in the palms and soles, whenever you see this maculopapular nodules which are painful in nature, if they are painful, they are Osler nodes. If they are painless, then they are Janeway lesions. Janeway lesions are the vascular phenomena, but these Osler nodes are immunological phenomena. Okay, these are the two different points which I want to know. Apart from this, what else you should know? The four criteria are completed. Fifth criteria number 5. We are discussing about the minor criteria. See, the first minor criteria is pre-existing heart condition, or IV drug abuse. It is the one thing. Fever is the second minor criteria. Immunological phenomena like post-streptococcal glomerulonephritis, Roth spots or Osler nodes, they are the third minor criteria. The fourth minor criteria is the vascular phenomena due to the septic emboli like Janeway lesions or arterial emboli, and Janeway lesions, splinter hemorrhages. These are all the vascular phenomena. Now the fifth minor criteria which I want you to know is positive blood culture. Okay, positive blood culture, but it is not enough for the major criteria. See, to establish a major criteria, see, positive blood culture is also coming under the major criteria, but to say it as a major criteria, you need to have two positive blood cultures. For example, imagine there is a patient who is having fever. You can see Osler nodes, Janeway lesions, Roth spots, all these things are there. Now, whenever you do blood culture, only one blood culture is coming positive. You have done three blood cultures. Out of these three blood cultures, only one blood culture is coming positive. So you should take it, you cannot take it as a major criteria. Now, if only one blood culture is coming positive, then it should be regarded or it should be considered as minor criteria. Okay, positive blood culture, not fulfilling major criteria. Not fulfilling the major criteria. That is one positive blood culture. Again, so these are the 5 minor criteria I have already discussed. So what are the 5 minor criteria? Pre-existing heart conditions, fever, immunological phenomena, vascular phenomena, and positive blood culture, which is not fulfilling the major criteria. Apart from this, some other clinical features which I want you to know is, see, these septic emboli are there, right? The septic emboli, okay? This arterial emboli, the septic emboli are there. They are getting disseminated throughout the body. So when they are getting disseminated throughout the body, imagine now the microorganisms, they are having a party throughout the body. So what our body need to do? Our immune system need to kill these microorganisms. Okay, our immune system have to attack these microorganisms. So as a compensatory mechanism, what will happen is there will be massive splenomegaly. Okay, because actually it's a complication. So there will be massive splenomegaly. So this is a very important point. A patient who is having infectious endocarditis, the first important point is a new onset heart murmur, and there will be massive splenomegaly going to be there. Okay, and even pulmonary infarcts are going to be there, right? See, these small microemboli, this septic emboli, they are going to be lodged in different parts of the lung. So do you think proper oxygenation will happen? No, now the arteries are getting blocked. There is arterial emboli. Now all the pulmonary capillaries are going to be lodged with this small emboli. So proper oxygenation cannot happen. So that may lead to clubbing. Okay. And one more thing. See, this microemboli, they are getting disseminated throughout the body. What happens if this microemboli is now blocking some of the cerebral vasculature? Some of the cerebral vasculature is getting blocked. So that can lead to hemiplegias. So all these are the complications, especially because of the microemboli. That is a vascular phenomena. So massive splenomegaly is going to be there, clubbing is going to be there, hemiplegia are going to be there. All these are the clinical features. Okay. Now, let's discuss about the treatment part. Now, what to do? This is a very severe condition, very serious condition. Okay. So the patient came, he is having so much fever and it's not getting controlled. Now, what you need to do is first start the empirical treatment. Okay, we don't know which microorganism is causing this infectious endocarditis, we don't know. So let's start with the empirical treatment with penicillin G or ampicillin. Penicillin G or ampicillin can be used along with gentamicin plus methicillin or vancomycin. Okay, so penicillin G or ampicillin, both are penicillins. So one penicillin, okay, one gentamicin or methicillin or vancomycin. Gentamicin is one thing. You have to use the gentamicin. So penicillin or ampicillin, gentamicin plus or minus methicillin or vancomycin. So this is the empirical treatment. First you have to start with the empirical treatment. Okay, so start with the empirical treatment and take the blood samples and send it for the culture. So after the blood culture, you will know which microorganism is exactly causing this problem. So after obtaining the blood culture, start the appropriate treatment. So appropriate treatment is done after attaining the culture. Okay, if the organism is a Hesse group of organism, okay, I have shown you already Hesse group of organisms. If Hesse group of organisms are causing this infective endocarditis, then treat it, this is an MCQ, treat it with the third generation cephalosporins like ceftriaxone. Okay, third generation cephalosporins like ceftriaxone is used for the treatment of infective endocarditis due to Hesse group of organisms. If there is a valve abscess, okay, normal antibiotics cannot go into the abscess, cannot penetrate through the abscess. So if there is a valve abscess, then you have to go with the rifampicin. Okay, it's an anti-tubercular drug, yes, that one. So rifampicin is used in the conditions of valve abscess. Okay, so these are some important points which I want you to know. So with this, the topic of the infectious endocarditis is completed. But I want to add two more important points. See, Duke's criteria. We have discussed that Duke's criteria, modified Duke's criteria is used to establish the diagnosis of the infective endocarditis. Okay, so with this, we have completed the topic of infectious endocarditis. Hope the video is helpful. Thank you.